طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. This is our second uh, virtual grand round for Sudanese Infectious Disease Association, and we're pleased to have Dr. Yasir Hamad talking to us today. Yasir, please introduce yourself very quick and then start the ball rolling. So, thank you.
السلام عليكم ورحمة الله. شكرا للاستضافة. دكتور ياسر حمد, both infectious disease and critical care trained. Today we'll talk about adjunctive steroids for community-acquired pneumonia. Is it time to change our practice? And this talk was prompted by the relatively recent New England Journal of Medicine article, big clinical trial on this topic. So no disclosures that are relevant. We'll start with this clinical vignette. So we have a 33-year-old male with recent hematopoietic stem cell transplant about 2 months ago, who presented to the day hospital, which is kind of in our hospital like ER/outpatient, with cough and shortness of breath. And they found that he was hypoxic. He required up to 50% with a high flow nasal cannula to keep his saturation above 92%. Chest X-ray showed the right lower lobe infiltrate. His labs were significant for low neutrophil count and high lactate. So patient is being admitted to the ICU, and the primary team asked if the patient should receive hydrocortisone, given the recently published evidence. So we can have votes by chat or by, I don't think we have a poll, or I don't know how to activate it. So A, yes, start hydrocortisone 200 milligram daily. B, no, we shouldn't do that. And C, well, it depends. And if somebody can tell me, I can't see the chat myself, but if there's any answer. So we have 1 no, okay, and then 1 C. We need 1 more answer. And another C.
What about don't know?
Okay, D, 1 D. All right. Okay,
I'll go with C.
Go with C too. Good. All right. So we have a majority of C and then a couple of B's and D's. Okay. So let's go through the evidence. So through this talk, we're gonna first go through like what was the literature before the article of interest, and then and the rationale, like what's the pathophysiology and why people are thinking about using steroids in pneumonia, and then talk about the Cape Cod study, which is the New England Journal study, and then review some of the recent meta-analysis before and after inclusion of the Cape Cod study. So, Bismillah. So as a background, so adjunctive corticosteroids have been used in many infections with actually good improvement in outcome, including like meningitis, tuberculosis meningitis, PJP, especially severe one, and septic shock. And and the outcome in community-acquired pneumonia, as we will see, is still like there is relatively high mortality rate despite, advanced care and supportive care and antibiotics. So people are still looking how to improve this further. So that's why the question of steroids comes to mind. And the mechanisms of action of a steroid could be through several pathways. One is by acting to help with the relative corticosteroid deficiency in critically ill patient, and that's kind of the rationale for like septic shock. They relatively have low cortisone level. And then two, by acting as a local anti-inflammatory effect and reduce the damage that happens by the immune system when it fights the infection. And three is in a similar effect with the Herxheimer-like reaction, like in syphilis. When you give the antibiotics, some people develop really severe reaction from the death of the microorganisms that are very sensitive to the antibiotic that can result in a significant inflammatory response. And very briefly, if you look at this graph here on the right side with the nucleus in display, so there are three mechanisms of corticosteroids. Two of them by acting with its receptor and going into the nucleus, either binding into this glucocorticoid responsive element where it changes the transcription of certain genes and proteins and downregulate others, leading to reduced inflammatory response, or acting in different region in the NF-κB element and also blocking the production of certain messenger RNAs and inflammatory response, or directly acting through the cytoplasm by also affecting some of the anti-inflammatory proteins. So what are the mortality rates in community-acquired pneumonia? So a few people looked at this, but of course it depends on what you look at and what subpopulation. But in general, it ranges between, this study looks at 10 to 30% and up to 54% when you look at certain high-risk groups like septic shock or multi-lobar involvement or inadequate antimicrobial therapy. There is a relatively recent study in 2017 looked at administrative data in the US and kind of made some estimation of the total number of hospitalizations and mortality in the US. And it came up with over 1.5 million admissions in the US alone, let alone outpatient management, and resulting in over 100,000 deaths annually. So an average 30-day mortality was 13%, and 1 year mortality is approaching 33%. And when you look at certain factors, you see that ICU hospitalization was associated with higher mortality, 18% versus 5%. And then a risk class 4 and 5, relatively high mortality, especially when the patient is in the ICU. And this risk group is coming from it's called FINE classes, which is the PSI, Pneumonia Severity Index, which I think some of the studies we're going to talk about actually touched on that. And it's basically a score that takes age into account. And for women, since they are actually somehow, as you'll see, that women have lower risk of a lot of infections. So here, women, you take 10 years of their age for the score. And then depending on coexisting comorbidities like malignancy, you add certain points, presenting signs like they're tachycardic or altered, you add certain points. And then there are points for radiology and laboratory findings. And then you end up with a score that goes from 1 to 5, with 1 having almost 0 mortality and 5 having 27 mortality. And if you look 4 and 5 are relatively the high risk mortality between 9% and 27%. So looking at some of the studies that looked at the use of steroids in community-acquired pneumonia, so some of them looked at non-severe or non-ICU patients. Others were mixed, and some were pure ICU patients. So I'm just going to pick kind of a representative sample from each group, and then we'll talk about the meta-analyses. So Mejevis et al. From 2011 looked at patients hospitalized with community-acquired pneumonia, and they specifically excluded ICU admissions, and randomized patients to dexamethasone 5 milligrams versus placebo, about 300 patients in total, and they did not find any difference in length of stay, which was their primary outcome, or mortality between the two groups. Another study by Snitgers et al. Looked at mixed population, including both ICU and non-ICU patients, and they used prednisone, again, about 100 in each arm, and again, no difference in mortality, and no difference in clinical cure, and actually more late failures in the prednisone arm, like having worsening presentation or clinical picture later on. While Blum et al. Also looked at the mixed population, used again prednisone, and found no difference in mortality, but they found that they actually got better quicker. And you notice here, this was relatively a bigger study, almost 400 in each arm by Blum in 2015. And then Wittermans et al. Also looked at the mixed population, used dexamethasone 6 milligrams for 4 days, about 200 participants in each arm, and they did not find any difference in mortality. But again, similar to the Blum study, they showed shorter hospital stay in the steroids group, and but not much, like about half a day less. And but again, they saw more hospital readmission trends in the dexamethasone. So a little bit shorter hospital stay, but maybe there is later complication, like patient get better quickly, but maybe they have kind of a relapse of symptoms. And then the studies that looked only in severe community-acquired pneumonias. So there was a study early on from Italy by Confalnori in 2005, and they only looked at ICU admissions. They have a very small sample size, like 20 in each arm, looked at a continuous infusion of hydrocortisone of 240 milligrams per day for a week. And they saw almost no mortality in the hydrocortisone group versus 30% in the placebo group with a significant difference. And they also saw some of the improvement in the secondary outcomes like oxygenation measured by the P/F ratio and less delayed septic shock in the interventional arm. Fernandez et al. Tried to kind of replicate that, but they used methylprednisolone 200 milligrams, which if you count the equivalent, it's a much bigger dose than the hydrocortisone study. Also 20 in each arm, but here they did not find any difference in mortality. But they saw a trend towards lower mechanical ventilation rate in the methylprednisolone group. And then the last two, before we move on to the meta-analysis, is the study by Torres et al. Looked at methylprednisolone, these two studies, 16 each arm, no difference in mortality. But when they looked at the composite of treatment failure, which include progression in the radiology, some of the late worsening of symptoms or worsening of oxygenation, they found that the placebo group had more progression towards a worse outcome. Meduri et al. This is another big study actually. This is a large, relatively large, well-done study, about 300 participants in each arm. This was conducted in the VA, and they didn't find the difference. They used like 40 milligrams in daily for 7 days with a taper. But in this study, they actually were planning to recruit over 800 patients, but they have very slow recruitment, and there was a delay in assigning patients. So like you can see, relatively the median time to randomization to receive the drug was almost 2 days. And you can argue that might be too late if the patient is already severe case. So in summary of the studies that we mentioned, I organized it here by the drug. So the one study that used hydrocortisone, the Confalonieri's study, showed a significant difference. Two studies that showed used the dexamethasone, no difference in mortality, but in one there was improvement in the length of stay. And then the two studies that used oral prednisone, again, no difference in mortality, but there was some improvement in time to stability in one. And similarly to the methylprednisolone trials, no mortality difference, but improvement in composite outcome in one. So still the picture is not very clear and very blurry. And so some of the questions, could that be because they're just having like a small sample size? That's why, and this was just like aberrant study, like the first study, or there's something else. So a lot of people try to summarize all the trials and do meta-analysis to see if they see a trend. So the first one by Burrell et al. Published in 2018 at SIDA looked at 6 randomized trials, basically including the study that we just mentioned, in total 1,500 patients. And they looked at primary outcome of this meta-analysis with 30-day mortality. And these are the studies that we all were just discussed and representing the different interventions. And when they compared the two groups, they noticed a couple of things I kind of highlighted is, as I said, relatively lower female percentages, but it's similar to both groups, like 30 to 40%. And then only 10% of them required ICU upon admission. So this is relatively a less sick population, including in all those studies. And if you look at the PSI score that we just talked about, only 16% in the highest risk group, class 5, and about 30 to 40% or 30 to 38% in class 4. But the majority of them are in the lower risk classes of 1 to 3. And pathogen-wise, the streptococcus was the major pathogen, as we expect. And some of the diabetes and COPD were among the participants. When they looked at the outcomes, so all-cause mortality, when they summed all of these, was not significant. So 5.9 versus 5%. But they showed a reduction in the length of hospital stay, even among this less sick population, of about a day, and decreased time to clinical stability also decreased by about a day. And rehospitalization increased, as it was shown on a couple of the studies that we discussed. In addition, there was also increased risk of hyperglycemia here, but they did not see increased risk of secondary or nosocomial infection, which you worry about, with these patients. No increased risk of empyema or GI bleeding with the use of steroids. So still the jury is out. And then they tried to do subgroup analysis, but they're relatively smaller numbers, but they did not see any difference between lower risk versus high risk, or ICU versus no ICU admission. But as I said, the majority of their patients 90% were non-ICU patients. So still sample size might be an issue. Another meta-analysis by Stern et al., this was actually the Cochrane group, who are known to do really well studies. So they looked at 13 RCTs. Their study included 17, but 13 of them included adult patients, almost 2,000 patients, 11 trials reported mortality. And they looked at the risk of bias to kind of categorize groups. So 6 of them were like relatively well done. So with low risk of allocation concealment bias, which according to the Cochrane group, this is one of the major criteria to tell you if the randomized trial is biased or not. Because if you're allocating patients without blinding, or then you run the risk of assigning sicker patient to placebo or less sick patient to your interventional arm if you wanted to see a positive result. So in this one, they actually showed lower risk of death in severe community-acquired pneumonia, mostly derived by the open-label studies. So steroid use was associated with lower clinical failure rate, which was a composite of death, worsening imaging, and no clinical improvement. Also shorter time to cure and shorter hospital stay, similar to the other meta-analysis. And this is summary of the results. So this is the forest plot, and it's basically a way to summarize all the studies in your meta-analysis. So we see here this is comparing corticosteroids versus placebo, looking at mortality in adults. So here is corticosteroid group, here is control, here the name of the studies, and here is the risk ratio with the line representing lack of significance. So if any of the diamonds or the whiskers here cross the line, that means they're not statistically significant. And then these diamonds represent summary of the groups here, and this is the overall total. Another kind of important point to notice is the weight. The weight of the study represents two things. One is the number of participants in the study and the number of events. So if you have a really large study, but you didn't have much of mortality, it will be lower weight than a similar size study with more death events. So the top group here is the studies with lower risk of bias, and the bottom is the studies with unclear risk of bias, whether it wasn't clearly identified or stated, like how they allocated patients, if the randomization was concealed, if it was random numbers, or who decides who goes to which group. So in the top group here, we see, the summary, kind of the estimate was all on the left side except of one or maybe two, but most of them crossed the midline. And then the overall summary, the risk was 0.8, which is less than 1, so it means favoring steroid. However, the 95% confidence interval crosses the 1, so it's not significant. With the unclear risk of bias groups, again, a lot of them on the left side, but they cross the midline. But the overall summary, they kind of like almost a third of the risk ratio, 0.3, and it doesn't cross the 1. And when you sum everything all together, there is a potential benefit of favoring steroids, and that is statistically significant. So with this, we'll look at a couple of other forest plots. So this one is looking at mortality, including only patients with severe community-acquired pneumonia. And as we see here, they also split the groups based on risk of bias. And but the overall, if you take everything together, there was a reduced risk of mortality in patients with severe community-acquired pneumonia. When you look at non-severe community-acquired pneumonia, you can see here everything exactly on the non-significance line, and with, again, the total sum of the studies showing no significant improvement. Looking at early clinical failure, you look at severe versus no severe pneumonia. Again, both of them were significant. And this one is time to clinical cure, and you can see there is a risk difference of about almost 2 days in the steroid arm when you sum up all the data together. And similarly, length of hospitalization was reduced. So based on this, the 2019 American Thoracic Society and IDSA published their guidelines on pneumonia, and they said they recommended not using steroids for non-severe pneumonia. So like they recommended against the use of steroids in non-severe pneumonia, but on the severe pneumonia, they still felt that there was no convincing evidence. So they said they suggest a little bit milder language, not using steroids in severe community-acquired pneumonia, other than what's clinically recommended for septic shock, for stress dose steroids in septic shock, which is not for pneumonia, but for the pressure requirement. So with that background, now comes the Cape Cod study, which was a study that was published in the New England Journal of Medicine in March of this year. And it was conducted by a French group, multi-center over like 30 ICUs in France between 2015 and 2020. It was registered a priori. They published their outcomes, so everything was documented. You want to know that because you don't want them to say something and then they find a different result and they change the outcome. Double-blinded, placebo-controlled. And they used centralized electronic randomization where patients, providers, and investigators, they were all blinded. Nobody knew who was getting what. And it was funded by the French Ministry of Health, which is a positive thing because, if it's funded by the producers of whatever steroids, even though most of them are generic, then that might introduce some bias. So their PICO question, their population is adult patients admitted with severe community-acquired pneumonia. The intervention was 200 milligrams of IV hydrocortisone that was infused through 24 hours for 4 to 7 days. Basically, they give him 4 days. They assess certain markers. If the patient improved, then they give just an additional 4 days. If the patient didn't improve, then they finish 7 days of hydrocortisone and then give another 7 days of taper. So the total duration would be 8 to 14 days. And then the control arm or the comparator is placebo. IV bag looks exactly the same, and it just has the patient ID, and it was, as I said, blinded. And then their outcome was 28-day any-cause mortality. And this is basically kind of saying what I said. So initial 4 days, assess the patient. If they got better, taper for 4 days will be the bottom line. If they didn't get better by 4 days, then they finished 7 and 7 days of taper. So a total of 8 versus 14. So inclusion criteria, in addition to what we said, like adults, and they have to have Social Security. That's a way to kind of assess mortality if the patient got discharged early or they lost follow-up. And they looked at the patient, of course, has to have a diagnosis of pneumonia clinically with infiltrate and imaging. And then it has to be actually diagnosed within 2 days of admission. So this is relatively an early intervention study. And then the study has to be infused within 24 hours of very severe tachycardia. So if the patient starts requiring high oxygen supply or anything, within 24 hours of that, he has to receive the study. Otherwise, he won't be eligible. And of course, has to get antibiotics. And they define severe pneumonia by either PSI class 5. Remember, that's the highest risk group with almost 27% mortality, or patient requiring mechanical ventilation, whether it's invasive, like intubated through the endotracheal tube, or non-invasive, like BiPAP. And or requiring like high flow nasal cannula over 50% with their calculated PF ratio of 300, or non-rebreather mask, again, with also very high or a low PF ratio as shown in the graph here. They excluded patients with septic shock, aspiration pneumonia, and then they post-obstructive pneumonia, patient with a positive flu test, and patients who are myelosuppressed or needing chronic corticosteroids for any reason, and on chronic steroids, as well as pregnant women. So a lot of the highlighted patient here is kind of the immunosuppressed patients are kind of excluded. I guess not all of them, but many of them who are on steroids or they have myelosuppression or similar to the patient we presented initially. And then septic shock patients, they kind of felt that was already an indication. So if we include them, that might weaken the association. So I think we went through this centralized electronic randomization. And then they stratified by study center. So each center will have equal number of both arms, and also mechanically ventilated and non-mechanically ventilated will be about the same, split between the two groups. Secondary endpoint, they looked at a lot of things, including like newer requirement of mechanical ventilation, vasopressor requirement after admission, and then the ICU length of stay and mortality at 90 days. They also looked at biomarkers and secondary infection for safety, I guess, endpoint, secondary infection, hyperglycemia, and GI bleeding, I think was one of them. So sample size calculation based on their assumption of a 27% mortality, I guess, based on their high-risk group, and they felt that the placebo will be like 27 placebo and 25% reduction of risk. So they expected the intervention to result in a 20% mortality. So they estimated that they will need about 1,100 patients to provide 80% power for a two-sided p-value of 0.05. And then they planned a prelim analysis at 400 and 800 patients for this study. So they screened over almost 6,000 patients. And out of those, 5,100 were excluded for these reasons, mostly septic shock, aspiration pneumonia, or flu, or steroids. Ended up leaving with about 800 patients for inclusion. So this is the recruitment over time. So on the x-axis, you see the years. On the y-axis, the total number of patients. This is kind of just shows you that it wasn't like, a whole lump sum in the beginning and then they stopped. It's kind of more like a steady recruitment throughout the study. And we know what happened at the end of the line here. That's probably correlated to the beginning of 2020. That's when the COVID hits. And of course, they have to actually hold the study, and they kind of made a sub-study using their infrastructure for COVID. But this is another example how COVID affected a lot of the clinical research. So it ended up resulting, another 3 years later because of the COVID, even though they stopped recruitment at this time. So looking at the patient characteristics, about 400 in each arm, median age was 67, so relatively older population. And again, as I talked about it earlier, a smaller number of female, included about 30% in each group. And about over 40% requiring mechanical ventilation, split between invasive and like BiPAP, non-invasive, and the rest between high flow nasal cannula and then rebreather. And then the PSI class, look, like almost 50% are class 5. Remember, the other meta-analysis had only like 15% of class 5. So this is a much sicker population, more mechanical ventilation. And then vasopressors on admission, and I think were about 10% or so. And these were patients who they did not think they have septic shock, but for example, they got some sedation or something and their blood pressure dropped. So about 10% in each group. So results. So the primary outcome, mortality at 28 days was significantly reduced in the hydrocortisone group, 6% versus 12% in the placebo arm, with a risk of 5% difference between the two groups, and statistically significant. They looked at certain things like 90-day mortality. They were also, the difference is 5%, and it doesn't cross the 0. And here they looked at the hazard ratio of like requiring endotracheal intubation, and it was reduced in the hydrocortisone arm. Here it doesn't cross the one, since this is like a hazard ratio. And they also requirement of new vasopressors was also lower in the intervention arm. Looking at hospital-acquired pneumonia infections, so looking at secondary infections because of the steroid, people are worried that it causes immune suppression. There was no significant difference between the two groups. And GI bleeding also was about the same. However, as expected, there was more insulin requirement in the hydrocortisone group. This is, relatively a good dose of like 200 milligrams a day. And no difference in weight. This is some of the charts that kind of look at some of the outcomes. So this is a percent of patient discharged from ICU versus time. And you see there is more hazard ratio of being discharged, so like higher likelihood of being discharged if you were in the hydrocortisone group. And this is the for patient who did not receive any mechanical intubation of patients who were not receiving mechanical ventilation at the beginning. You see the hydrocortisone group was a lower risk, but there's some overlap. If you look at this is the 95% interval over time. And this is intubation for patients who were not intubated, kind of similar results, also significant. And similarly, secondary use of pressors was significant. So this one is looking at subgroup analysis in the mortality. And they looked at patients who were receiving mechanical ventilation or not, isolated bacteria or not, and more than 65 or less than 65 PSI, that's group 5 or not, and some inflammatory markers, and this is the overall difference. But the thing here with subgroup analysis, I guess there is a trick that you can use to see if there is significant difference between group, is to look at the summary, the overall patient's outcomes, and look at the summary estimate, which is this black box here. I don't know if you see my mouse, like arrow, but I think I can use this one. Okay, this is better. Yeah, so you look at this summary point and just make a line across it like this, going all the way up. So if it crosses both groups, then it's basically there is no significant heterogeneity between the two groups. So the strength of this study is that it was multi-center design, large sample size, relatively this is one of the largest studies. And then they randomized patients with concealed allocation, lower risk of bias, and they had an objective outcome. You can say, nobody would argue that patient died or didn't die, so some solid outcomes. The limitations, though, they were expecting a higher mortality, so they powered the study for 27%. The mortality was relatively lower risk in the placebo, like 12%. And then a lot of the studies that we reviewed before has not really replicated this finding, so it's kind of newer finding. And they excluded patients with septic shock, but I think that's probably, I think you can understand the rationale is because that's something already indicated in the guidelines. People should get steroids, so they didn't want to confound their results. And they have relatively small number of immunocompromised patients, so even if we follow these results, can we generalize this to immunocompromised patients? I think that will need additional studies. And then they used hydrocortisone infusion as a continuous drip, which can be logistically challenging. Some patients might have limited access, especially if you're talking about like sick ICU patients with multiple drips, non-compatible. And the other thing is this most of the hospitals, they don't use continuous infusion of hydrocortisone. So this might also introduce errors since pharmacies are not used to this kind of thing. So maybe add a zero or take a zero off, so resulting in wrong doses. So then a couple of actually meta-analyses were conducted after this study was published. So this one by Wu et al. Published in Critical Care this year too. They only summarized, looked at trials that included patients with severe community-acquired pneumonia. So ended up with 7 studies, 1,700 patients, and comparing the 30-day mortality between the 2 groups to see if this is kind of like consistent with severe pneumonia. And these are the studies. So you notice the first study, the Queen et al., this is the study that we just discussed by New England Journal. The Meduri et al. Is the VA study that we reviewed before. It has the relatively slow recruitment and delayed time to administration. And then some of the older studies, including the Italian study by Confulano Rear. We did 20 groups that showed a significant difference. But these have the bigger like N. So like between the 2 of these, you have almost 800 and 600. So like 1,400 patients. And then this is looking just at the severity of the 2 groups. So these are the different studies, ages, and male versus female, and then the disease severity. And then here the mechanical ventilation and ICU admission. So you notice that the Queen et al. Patients, all of them were ICU. The Midori et al. Had a mixed population, but they didn't report the actual numbers. And then the rest between 70, 80, 100%, most of them were only ICU patients. And the mechanical ventilation rate ranged between 30% to 65%. So very high risk and severe and higher severity scores in these included studies. So then they looked at the all-cause mortality, and you notice all of the studies, their summary point is on the left side, so favoring steroids, and a lot of them cross the non-significance line. And the size of the square here represents sample size. So you see the Midori et al. Actually, sorry, it represents not the sample size, but the weight. I remember the weight is the combination of the sample size and the events. So even though the Midori et al. Has a relatively smaller number of patients by about 100, but they had more events. So they had higher weight than the New England Journal study. But again, the summary endpoints were statistically significant, favoring the steroids, and it does not cross the one line, so 60% reduction in the risk ratio. And then here, looking at the risk of mechanical ventilation, if you were not on the ventilator and you got the placebo versus control, again, significant reduction in the total summary statistics. And then looking at length of ICU stay, I mean, maybe a reduction about a day or so. It's barely statistically significant. And then looking at adverse events, I think this is what's a little assuring because and the summary endpoints showed no increased risk of GI bleeding, no increased risk of secondary infections, and no increased risk of the acute kidney injury or hospital readmission, even though this is kind of the summary on the right side, but it's not statistically significant when you summarize all the studies together. But so in summary, evidence is building up that's supporting the use of corticosteroids in severe community-acquired pneumonia. And many patient populations, though, were excluded. So whether this will apply to them will need further studies. As we talked about the immunocompromised patients, hospital-acquired pneumonia was not included in this study. So this is community-acquired pneumonia. aspiration pneumonia has been excluded in many of the studies, as well as viral pneumonia, even though a lot of the studies actually ended up including some of the patients who later were found to have viral infection, but they were a minority of patients. So there are questions left to be answered. So what's the optimal regimen? So even if we wanted to say, okay, let's apply this in real life. So which medication are we going to use? Are we going to use the hydrocortisone, methylprednisone, dexamethasone? If we just take the drug that was used in the New England study and use hydrocort, should we use it as a continuous infusion or give like 100 Q8 or 50 Q6, or what's the optimal regimen? I think that's something needs to be looked at. When should we give the steroids? I mean, is there a time limit beyond which we shouldn't give the steroids? As we saw the Midori et al. The PA study, they gave medication about 2 days after patient had severe criteria, and there was no statistically significant clinical improvement. While in the DeQueen et al., I think their median time to administration was less than a day, like 17 hours or something like that. So, and they showed an improvement. And the other question is this finding really generalized across all pathogens? Or is it similar to meningitis, the story with the steroids in meningitis, only driven maybe by the streptococcus, because it's also the major contributor of community-acquired pneumonia. So, and then between the different pathogens, like, as I said, viral versus bacterial, who should we give it to? So I think that my last slide. Yeah, and then with this, I'll finish and happy to take any questions. It's tough to see people.
Thank you, Yasir, for the nice presentation. I have a couple questions. Anyone did any animal studies to see if there is any pathological benefits? And the other question is, how about inhaled steroids? Did they, or these patients with inhaled steroids excluded from these studies, or anyone did look at inhaled steroids as a treatment option also?
Yeah, I mean, the studies I looked at all were like human studies. I think some of the pathophysiological studies, like the one I showed earlier, I think some of them may be driven by animal studies. But yeah, I haven't seen any study used inhaled steroid, and I think part of it is the thinking or the rationale that, you know, the pneumonia will induce more like a systemic inflammatory response, and you need something more like systemic administration to control that. But yeah, I haven't seen any study like using inhaled steroids as a measure and showing any improvement. Yeah. Dr. Fathy,
Yasir, thank you so much. Very interesting presentation of a very difficult subject. Why do you think all the recommendations for steroids come from France? You know, the difficulty we had with septic shock is always been to use steroids or not to use. We use high dose, and then they said it is harmful. Then they came with the Anani study. Anani is from Paris, I think, who suggested to give septic shock 50 milligrams Q6 hourly. And then again, this study came, the recommendation came against it, and septic shock, now we give it in a very small group of patients who will require very high dose of inotropes. And now they're coming with this study for pneumonia, and they say you have to give it. I don't know. I mean, I think we have to wait for time to prove this. I mean, just one comment is, did they dissect the patients who had community-acquired pneumonia due to pneumococcal? versus others, no organism or a specific organism? Because we know in an acute bacterial meningitis, it is only the pneumococcal which stands the test, or stood the test, sorry.
Yeah, so yeah, you're right. A lot of the studies, especially in critical care, are coming from France, and I think they have an advantage of having like a health system that's well connected, and they can easily conduct and recruit through like many ICUs, and I think like for example, the US here is very challenging, like to conduct such a big study. It's gonna require a lot of resources and building a network of hospitals. There was the ARDS net like group, but then that kind of limited themselves in just ventilator and certain things. But I mean, it would be nice to be replicated, in other settings like here in the US or maybe in UK but similarly, actually, a lot of the, as I said, in critical care, like the proning studies, I think also came from France. You mentioned a lot of the steroids and septic shock came from France. So I think unless we prove them wrong, I mean, based on what they like going through the process that they went through, looks like it was a well-conducted study, but I think replication will need to be, will give you more confidence. And I mean, the meta-analysis also is assuring that, when you sum up all the evidence, it's kind of supporting that. But I agree with you. In terms of the looking at pathogen, there was actually another meta-analysis that's, I think, being published at SIDA. So actually one of the PIs here at the NIH was recruited as to review the article, and he included me. So that one actually looked at the separating streptococcus versus not on the few studies that reported the organism, or looking at studies that has pathogen identified versus not, and they did not see a statistically significant difference. But I think that's also limited by the many times, like over 50% of the cases, we don't know the pathogen. So I think that's confounding the result. And maybe the numbers are getting a little small when you look at only studies that identify the pathogen. So I think the jury is still out there. So I think we need a better study looking at, whether you randomize, certain pathogen that will result in a difference in outcome versus others.
I have another question, Yasir. Do you think all the differences in these studies, anybody looked at what antibiotics they're using as their guidelines for treatment, or no mention for the antibiotics?
Yeah, I mean, I think in this study, they did mention, like, they basically followed their guidelines. They're using like either third generation cephalosporin or amoxiclav, I think. And so it seems to be like, and then some atypical coverage. So for more severe cases. So it seemed to be like appropriate coverage for their, based on their guidelines and things like that. And they required patients to at least receive a dose of antibiotics for these studies. And I think they excluded patients who already received like a course at home or something of 7 days. So they really, I think they did a good job in picking up more acute cases like early on. Because if you think on the meningitis side, like when is the benefit? Benefit is if you give the steroids at the time of the first dose, right? Beyond that, it's you kind of really lose the effect. And but I guess meningitis is more like critical because you're limited in your space, you can expand and all that compared to like pneumonia. But I think the earlier seems to be the better based on the studies, that at least the two big studies between the VA study and the French study.
Thank you for the interesting lecture. But going back to your first question, I was like really not in the beginning, I was like confident to say C. But now after the lecture, this patient, I cannot fit the patient because the patient was like transplanted patient. So by definition, he was like immunocompromised. So according to what you present to us, I cannot fit him in any like scenario. Maybe I will go with Dr. Fathi Zaini, I don't know.
Yeah, I tried to make it as confusing, but I think you're right. Yeah, most of the studies did not really address this population, and I think honestly, personally, I would not give this particular patient steroids because he's really immunocompromised. He's been excluded in a lot of the studies. He's already have low counts, but I think. Hopefully, we'll get more data in the future. But generally, if the patient is otherwise healthy, elderly patient, coming with the typical community-acquired pneumonia, getting severe, and it has to be severe. I mean, I'm not going to give it for milder or moderate. So, and severe has to be like either, requiring ICU admission or pressures or requiring mechanical ventilation or having, if you calculate the score of PSI class 5. So I think if the patient meets these criteria and has a community-acquired pneumonia, I mean, I'm leaning towards giving them steroids. But yeah, immunocompromised, especially severely immunocompromised, I don't think we have enough evidence to support that yet. Even though you could argue that this is the population that might benefit the most from reducing their, improving their outcome, but we're not sure about the safety too.
It will be interesting to see also what the French are doing after this study. Like, are they implementing this everywhere, or are they still thinking?
Yeah. Yeah, I mean, if you look at it, a lot of the studies, even in COVID, did not come from the US. Like, the recovery trial with the steroids in COVID came from UK. I think, I don't know if things here are super expensive or so many like bureaucratic processes. But yeah, I think the Europeans are leading us there in this field.
Any more questions? I think we're almost at the end mark. If no more questions, I'll conclude our session today. Thank you very much, Yasir, and hope to see you all again next month, inshallah.
Thank you for having me.
Thank you so much, Yasir. Thank you, Izzuddin.
Thank you. Assalamu alaikum.